The best part about having a podcast is having friends like Dara Kass on it. It's great to have you on the podcast again, Dara.
Thanks for having me.
So I got to know you through being founder of Fem&EM, and you've done a lot of other things. Can you catch our audience up on what you've been up to since, I don't know, maybe the pandemic?
Wow. Okay. So it's been like a decade since the pandemic started. So we went into the pandemic planning another Fem&EM conference, Fix, live and in person, actually in Chicago. That immediately fell by the wayside when we all started going to work more and really started staying home. And I found myself actually working a lot from home and doing a lot of television, a lot of public facing communication around what was going on. A lot of us in emergency medicine were either writing op-eds for our community, answering the call for local media, making sure our friends and family knew what was going on. And since I live in New York, which was the epicenter, I think there was a lot of conversation about what's happening here first. And so I found myself doing a lot of media over the couple of years from really March of 2020 through the end of 21. But I also found myself in a new position where in November of 2021, I started as a regional director at the Department of Health and Human Services. And this role was an appointment from the president. It's a political appointment. And it allowed me to understand more about what happens in the federal government, specifically how do federal governments work with state and local authorities, and also how does the delivery of healthcare occur at the health system level, at the individual provider level, and then also at the systems level, and where can we make change? And I was really drawn to that as somebody that had thought about systemic change around gender in medicine, around delivery of healthcare. So I started in the federal government in 2021, which actually coincided with like Fem&EM sunsetting. And I've told you this before, but when you're a federal government political appointee, you can't own or run anything that has any conflict with what you do in the government. So aside from having to divest and also resign from my position at Columbia, I actually had to stop running Fem&EM, and I haven't run it since 2021. I left the federal government in the beginning of 2024 to get back involved in the ground game, if you will, right? So in the middle of that time, while I was in the federal government, lots of things happened, including the decision that removed federal protection for reproductive health care nationally. And we saw over 20 states put in restrictions on access to care, which has had collateral effect to the care of patients who need reproductive health care emergencies across the board, whether it's ectopic pregnancies. And we'll talk about, I hope, about that a little bit more. But I really needed to get back to the work. I missed being in the ER more. I missed being with all of you. We're a posse. I mean, I'd say we're a squad, but we're bigger than that, right? We roll deep, we roll wide, and we roll together. And I missed that in the government. It's just not the same. I gave grand rounds yesterday at a medical school at a residency. And like, there's just something magical that happens when you put a bunch of ER docs in a room and give them a problem they think they can solve. And I'm ready to go back and do that again.
Well, we're so thrilled to have you back in the mix again. I am curious, though, after your time working in government, what did you learn? I've been working for and with the government since 2011. And a joke I make, and it is a joke, working for the government will turn you into a Republican. I am still a Democrat. But it's a joke. I can see you laughing because, well, just unpack that.
No, I don't need to. My husband says the same thing. And he didn't work for the government. His line is, if you're married to somebody that works in government, what he says is if you're married to somebody that works in government, you can certainly see how people believe in less government. And I will say this, bureaucracy is built to withstand sea changes. And we've seen the benefits and the problems with that. I went into the government to learn what the government does for healthcare and how I can see and propose solutions that I think can help people get healthcare, get more affordable healthcare, get better healthcare, solve the problems in front of us. What I learned is where the government should solve problems and actually where it shouldn't. What is it not built to solve? What problems do we need philanthropy to solve? What problems do we need local governments to solve? What problems do we need health systems to solve? And how do you fuse those partnerships? So while I was in the government, I did a few projects that were really public-private partnerships that were accelerations or pilots of stuff that the federal government wasn't going to do on its own. Maybe it was too bold or it was at the edge of what the federal government's even allowed to solve, but they had the amplification effect of connecting the kind of funder and founder to the population that they could need help with. And one of those was actually newborn baby kits. So we worked on a project where we helped connect a very large nonprofit with patients in really rural areas that needed better support for new mothers. And we were just the kind of connector, the catalyst. We didn't fund it, but we brought a brand and a information and a knowledge to it that meant that this nonprofit could connect better with people that needed these kits. And we envisioned a sustainability model that ultimately would be appropriated, which is the fancy government term for paid for, by the federal government, right? This is the idea that if this pilot could prove something that was worthwhile, better mental health for new mothers, better resource utilization, increased likelihood of postpartum visits, higher enrollment in postpartum Medicaid, then we could say this is a worthwhile expenditure of federal dollars because we've proven that this investment is worth it. Those are the projects that need to be done as partnerships between federal and local governments or federal governments and private organizations. And I know that. So now as I look to new problems to solve, and reproductive health care is one, I don't want the federal government to solve the entire gamut of access to reproductive health care, not because I don't think that it is a good solutions, like a good process to the solution. It's because I know how many people don't want that to sustain. And what happens if, and you can take this even further into universal health care, what happens when the government wants to undo access? Like, and we've seen the threats to the Affordable Care Act. If the federal government owns access to healthcare and funding for healthcare, and a government gets in place that wants to decimate that, where do people go? Right? How do they solve that? What we need to do in that way is embed it so deeply in legislation and in ways that cannot be undone in order to make it possible, because there are a lot of people who don't believe in universal access to healthcare, who don't believe that the federal government has any business in supporting the most vulnerable around us, and certainly don't believe that government should support all healthcare, not just the healthcare that they like. And even looking back at the pandemic, you could really look at perspectives or choices that people made in the name of their own government, local governments and stuff like that, that were done with a cost-benefit analysis. And there were harms to certain populations, but it was clear that those governments didn't prioritize those populations. And that's okay. Like, the thing I like about local government is it reflects the will of the people that pay local taxes. And I'm okay with people making different choices. I just think those choices should be pretty transparent. And so I'm not ready to give over all of healthcare access to the federal government just yet, because I don't trust that everyone that's ever going to be in control of the federal government is going to want to continue to deliver robust and expansive healthcare access to all citizens that are in the United States. Is that fair?
Totally fair. And I think what I'm hearing is the government is a really big entity, and what we're all craving right now is good government. We want the government that reflects our values and that works for the people. But it's a big, messy thing because we're a big country of 350 million people, and there's a lot of different opinions on that. One thing I want to just highlight for the listeners is you could have went and got a public policy master's, but instead you got a job. And I think that's a really important message to our audience that tends to be people that go after degrees, myself included. I'm finishing up a master's right now. But can you just speak to a little bit about that choice? And knowing you, I think it was a bit deliberate that you knew you could have gotten a master's or a PhD in public policy.
Yeah, I mean, I still can, right? I would say that, and it's funny because I am turning into even a bigger student as I get older, right? I love learning new things. First of all, I don't want to minimize the on the ground impact fact, like a fact of seeing things actually work and not work, right? So like learning content is not the same thing as seeing it delivered, right? That's true. And from medical school to your clinical years, you can see this. There's a lot of other things about being in the government, public messaging, connecting with people, the ability to immediately get involved in policies that were passed. So the Inflation Reduction Act was a huge piece of legislation that passed while I was in the government. I immediately got to go and hold events at senior centers talking about what was in that for patients that received their medications through Medicare Part D, which is the pharmacy benefit of Medicare. I think that degrees are important and we need people that understand how and why things go, especially for researchers. I'm much more of an implementations kind of girl. I need the connections with other people in government and also the kind of the constituencies. And it was just a better fit for my skill set, my broader skill set than just me consuming knowledge was this kind of back and forth. I mean, remember, I took the job as we were seeing another wave of COVID come through. So I had just finished being an ER doctor and communicating publicly on COVID, and then immediately was in the federal government as we were continuing to deal with policies affecting people's lives around COVID. So I felt like that real world experience made me a better government employee. And so I guess the long answer to your short question is it suited what I wanted to do better. It was better for me. And I got to test out things in real time more efficiently because I didn't just get a degree, which I don't want to minimize. I think degrees are important. But I also like what you're saying is true, which is real work also can be both informative and affirming.
Yeah, absolutely. And I think avoiding the trap of delaying what you want to do because you think you need another degree or more initials behind your name.
Yeah. And also remember that still being a constant student and learning, even if you're not in school, I spent a lot of time learning how programs were delivered. Like, how is Medicare delivered? How is Medicaid expanded? What does it look like for CMS to fund graduate medical education, right? I had done it as a assistant residency director. I knew a little bit about the funding of graduate medical education. But as we were talking about healthcare workforce issues, I went back into the root of the origination of how graduate medical education was funded and what policies would have to change to, let's say, allow people to retrain in new specialties mid-career if they felt that they were burning out from their specialty and wanted to do something else. One of the things I took into the federal government and a problem I'd love to solve in the 15th act of my life is we force physicians choose to be a kind of doctor when they're 25 years old, when they have enormous debt, and they're intrigued by all of medicine. And many times they choose the highest paid, most procedural, and sexiest specialty they can find and get into. And as you get older and you have many children and your life becomes more complicated and you're not interested in necessarily being on your feet all day, you may want to do something else. Physician's assistants, nurse practitioners, they can all change specialties. We can't. Wouldn't it be great to figure out a way to allow physicians to retrain or certainly recertify in other specialties that were appropriate for the level of knowledge or training so that they didn't have to just leave medicine, but they could pivot in medicine? And that to me is a problem that I think we need to be talking about more.
I couldn't agree more. I just had a wonderful podcast recording right before this one with Dr. Kara Pepper, who's an internist, and her entire practice clinically is with eating disorder patients. And I said, I had no idea that you could see eating disorder patients primarily. I mean, I thought it was the psychiatrist. And she's like, oh no, I do all the medicine side and optimizing their medical health so they can do the therapy and all the other things they need to do. And she has her own private practice doing that. And I just thought that was such a wonderful story of how she's found this niche that she loves, and that's what she gets to do every day.
Yeah, I think that, again, emergency physicians are a special group, but it's also not, in my personal opinion, and certainly from my experience, you can't do the 3 shifts, 2 patients to 3 patients to 4 patients an hour every day over the 24-hour cycle as you get older. And if you can, maybe we shouldn't, right? But that is a conversation for another podcast.
Well, let's pivot to, and speaking of pivoting, pivot to what you're doing now. Tell us about AccessBridge and what else you're up to.
So after I left the federal government, I spent a fair amount of time looking for the white space, as we say, about what would my skill set be good at, but more importantly, what needed to be solved. And Feminem, for anyone that remembers it, was at a time where we talked a lot about the workspace for everybody in medicine, but for women, professional development, lactation, maternity leave, but also promotion and support and gendered evaluations and all these things that you didn't have to be somebody who was going to become a parent to need support as a woman in medicine. But if you were also a woman in medicine who was becoming a parent, there were many more obstacles that you were going to have to find. But we also talked about what it was like to be a guy who became a parent, right? All the biases that men were facing when they were changing their schedule or whatever. So I really wanted to look for another area that I thought I could both solve and more importantly get involved in, because that's how I get energized, right? And I obviously did a lot of work in the government on reproductive health care and understood what part of reproductive health care the federal government can be involved in and cannot be, also related to legislation that either needs to be passed or certain amendments that exist in the appropriations bills, like the Hyde Amendment, which says the federal government cannot pay for abortion services unless it's rape, incest, or the life of the mother. So there's a lot of places that this needs to be solved outside of the federal government, right? And states are doing all kinds of shit. I mean, you're a native girl from Iowa, right? It's a week for Iowa. And
it's a real shame.
But staying ahead of even the knowledge base of where is care restricted, where is it not restricted? You're in Arizona. The Supreme Court says it can go, it can't go. Just now, literally 10 minutes before we started, the Supreme Court of Utah is allowing abortions to exist in Utah. It's like, even I need to unpack the dizzying effect of what's happening with reproductive health care in the United States. Yet, I understand a lot about where these different decisions lie. And as an ED doc who did a fair amount of work earlier on pregnancy emergencies, because I was somebody who was pregnant and in emergency medicine at some point, I felt like this was an area that I both was interested in and can make a difference in. And so in a lot of conversations about other areas that I was working in, other consulting that I was doing, I came across an organization called AccessBridge, which was actually a fledgling pilot that was rooted in a project on substance use disorder that was started by a group called California Bridge, which worked on substance use disorder treatment and navigators in EDs in California to help with medication-assisted treatment for patients with substance use disorder. And they themselves are an entity of the Public Health Institute. So the Public Health Institute supports a bunch of programs. They had supported California Bridge and its subsidiary Bridge programs. And then somebody that was there wanted to work on reproductive health care. And so they basically branched off AccessBridge, which is a project that is rooted in elevating the foundation of care in emergency departments around the country around reproductive health care. So what does that mean? It means that we're looking at all the ways that people receive care within reproductive health care in emergency medicine, starting at access to contraception, decision-making around ectopic pregnancies, management of miscarriage, right? So many people who have miscarriages come to the ED, and unfortunately, they're not always given the standard of care, which is medication support, and certainly the option for medication support or procedural care. Knowing who and how to give emergency contraception to, and then also offering medication abortion, if possible, in states and in communities where it's legal and advisable. So if a health system, for example, like in California or in New York, dispenses medication abortion from its family planning clinic, what stops us from dispensing it from the emergency department as well? This was something that I had wanted to work on in 2018 when I started getting more involved in politics. I never understood why medication abortion, which is simply the dispensing of a single pill followed up by 4 other pills, wasn't available in EDs. Like, people come to us with all kinds of medical circumstances and situations, and we prescribe them the medication that they need, yet we didn't do it, and we don't do it historically for this particular condition, right? And there are physicians that would like to prescribe this medication for this condition, and there's no medical knowledge reason why. In fact, we are better suited likely to do this in EDs, because by the time somebody, if they come in because they're pregnant whether they are coming in to confirm pregnancy or they're even starting to bleed, let's say, and they don't want to be pregnant, but the pregnancy itself is continuing, that's a conversation we can have with them. And so it always seemed to me that there was an opening to kind of increase this delivery of service in emergency departments without new procedures, without increasing staffing requirements, without policy change. So I was excited that they were even having that conversation. And so I started working with them on the protocols, and we started working on things like the ectopic pregnancy protocol. I think ED docs take it for granted, especially if you work in a state where abortion is still permitted, even if support's been expanded, that our treatment of ectopic pregnancy and pregnancy of unknown location involves shared decision making that ends a pregnancy that by some percentage chance often could not be ectopic. Now, that's a deliberate decision on us, right? We have a risk benefits conversation with our patient and we say there's a 99.9% chance that this pregnancy, which I cannot see on ultrasound, and your beta level is, let's say, 2,500 or 2,700. There is a small but unlikely chance that this is not an ectopic pregnancy, but I think it is based on the evidence I have in front of me. And I'm offering you medication to end this pregnancy so that you can go get pregnant again if you want to, or you don't have to worry. You don't have to come back. And ACOG gives a window of that decision, right? You can have that conversation between a beta of 2,000 and a beta of 3,500. Well, if you work in a state where elective terminations are not allowed, they lean on 3,500 as that clinical decision point. So you actually can't necessarily have that conversation before 3,500, and you certainly won't have that conversation under 3,500. And so we created a protocol for physicians in states where abortion is allowed and in states where elective abortions are not allowed, not because we're ever doing abortions. This is about ectopic pregnancy. These are pregnancy of unknown location. These are not identified on ultrasound, but it allows support to physicians who have to make that decision in real time to say, I live in Iowa, right? Abortion's allowed under up to 6 weeks. So I'm not in that window anyway, because this person's like, who knows what they are. But at the end of the day, I sent them for an official ultrasound. There's no IUP. Their beta is 2,700. ACOG says I can act. I'm gonna give them methotrexate. As opposed to what we're seeing happen, which is the patients are being sent home. They're being told to come back in 48 hours for a repeat beta and maybe even a repeat ultrasound. And it isn't to say that all of those patients are not getting ultimately treatment that they deserve, right? So if it eventually appears that it's an ectopic, they'll eventually get that medication. But we have been able to intervene earlier so that patients don't have to have 48 hours of anxiety that they're going to rupture an ectopic pregnancy while they're waiting to come back. And so I tell that very kind of long anecdote to say that there are opportunities for us to clarify the practice of emergency medicine as we have always practiced it in this new landscape of questionable legal restrictions that aren't about abortion, right? Like, again, it's this collateral damage effect of if outlawing abortion is here, how close am I to that line when I'm treating an ectopic pregnancy? And legislators and governors and attorneys general and lawyers don't know anything about where that line lives. And so it's on us to define that space with our best knowledge and evidence-based medicine that is best served for our patients. And again, not flout the law, respect it as it was passed by the legislator or whatever, but also remember that we don't want to harm our patients along the way. So AccessBridge has a bunch of protocols. And over the first year, we did these fellowships that were pretty cool. There's this kind of growth of these early to mid-career faculty development programs. This is funded, which is, I think, very cool. So it gives a little bit of a stipend for time. And it allows for up to 30 fellows a year across the United States to work on projects that are about expanding reproductive health care, whether it's initiation of contraception or better miscarriage management, which we can talk about, or ectopic pregnancy decision-making, or initiation of medication abortion where necessary and appropriate. But it also allows them to have support in research and support in education so that they can become disseminators of information. to do what I want to do, which is to lift up every emergency physician over the next 3 years around the country, no matter where they live in the care of this patient population, I need an army. I need to organize and to galvanize every ED doc around the country to find this space that they feel comfortable caring for this patient population better than they have been cared for in the past, and certainly better than a lot of them are going to be cared for in the future. So in addition to the fellows, we have this ambassador program, which is a kind of a play a little bit on what we did with Feminem, which is kind of a lower touch opportunity. If you just want to help develop contraception initiation in your ED and you don't want to do research and you're not interested in a monthly call with a mentor and all the things that you get from the fellowship, just become an ambassador. Our program, our policies and our protocols are available. But as you're working on implementing the protocols, there will be monthly calls that will have some experts or some resources like office hours that you can ask questions. So if you're trying to initiate contraception in your ED, what does the plug and play doc to hand to your IT department look like to get it in Epic? What discharge instructions could you use, right? How do you have a conversation with OBGYN or family planning about which contraception choices are best offered from your ED? Supporting implementers on the ground is a really easy lift when you're well organized. And so for next year, I hope to have 30 fellows across all states. And then I'd 100, more than 100 ambassadors in different kinds of hospitals, rural, academic, city, urban, Catholic, VC backed. I don't really care. I just want to know that in each department, there's somebody championing this kind of healthcare, because what we also know is that OBGYNs are leaving states. It's also getting harder to see patients. There's a woman named Caitlin Joshua, who you may have heard about. She's in Louisiana. Her story is pretty public. She was pregnant and could not get an appointment with a GYN in the first trimester, which historically is not a huge deal. There were decades where GYNs did not see patients in the first trimester, but then she started to miscarry and she had nobody to call. So she came to the ED, and the communication and the treatment around her miscarriage was suboptimal, it seems, according to her telling the story. And so whether or not she got offered a procedure to help her with the miscarriage or whether or not she got the right medications, at the end of the day, her care was suboptimal. And she had to go to more than one ED. And we are better than that. Like, I know ED docs. I know women in emergency medicine, but I know a lot of ED docs. We go to work to take really good care of our patients. And sometimes we just need a little bit of kind of a little wind at our sails to do better for patients when we're also feeling a little bit vulnerable as providers.
This has been such a beautiful story, and it's so on brand for the podcast this season, which we're highlighting change making in medicine. And I'm doing research on that right now, and I'm in the data analysis phase. And our theoretical framework for this study was that we need more physicians that move out of learned helplessness and harness their agency. And you are a beautiful example of somebody that is very in tune with their individual agency. And then your superpower is developing collective agency. So that's the type of terminology I want the audience to get more familiar with, because we can do things individually, but the problems we're trying to solve, we can't do them alone.
No.
And you need, as you mentioned at the beginning of your podcast, we need the posse. We need everybody, all hands on deck for these problems, which is a great segue for give me your reactions to the phenomenal news. Future President Kamala Harris. How excited are you?
No, I mean, I was not in a great place before, so I don't know what the bar looks like to get excited, right? And I will say, so obviously, I was in the federal government, and I also clearly identify as a Democrat, although I am a pragmatic person. So I would say that I want there to be a healthy conversation about how we solve problems, right? I am not somebody that's trying to cut off or polarize society. I would love there to be a healthy, contrary side to the decisions and the solutions that I see. However, sitting where I sit, I was pretty excited. I think that, look, President Biden is an extraordinary president. Like, if you pay attention to how policy is executed and the change in people's lives, this president is like literally, I don't rank presidents that often. I have a few friends that do, but top 5 on the stuff that he has done that make a difference in people's lives with only 2 years. Because let's be really clear, it has been the practice of Republican-led Congresses over my majority of my lifetime to not pass effective legislation that helps people. It doesn't mean that was always the case before, but somewhere around the time I turned 25, we had stopped seeing effective legislation being passed by Republican-led Congresses. Certainly, I should say legislation that is effective to do the things that I think need to get done, like expanding healthcare access, bringing down costs for regular people, making sure that we're investing in the future, those kind of things. And so in 2 years, President Biden passed huge legislation that invests in the future, climate, infrastructure, chips and science, gun legislation for the first time ever. And almost all of it was bipartisan, except for the Inflation Reduction Act, which was unipartisan. And that started the process of helping seniors have affordable healthcare. Now, I say that to say that since the federal government does not deliver healthcare, for the most part, like it delivers Medicare and then the VA, which is a totally separate thing. And then it partners with states on Medicaid, which is a very different conversation. In negotiation of drug prices, the best it can do is negotiate Medicare drug prices. It can't do a lot. It's a lot more complicated when they're working with private insurers on negotiating. And with the insulin negotiation, we saw that, right? They could get past Medicare negotiation for insulin at $35, but they could not get private insurers to do it the same way. So that shows us the leverage the federal government has. So having all that said, President Biden's amazing and has been an incredible president. I was really okay with him being a one-term president because you can't deny that he's, like a friend of mine says, he's 10 years older than he was 10 years ago. And that he, looking into the future and looking into the next 4 years and looking into the energy that we have and the problems in front of us, it would be amazing for us to say it's time for generational change. And I think what is so remarkable about him is there was a line, and when it felt like we were beyond that line, that him serving as president for the next 4 years wasn't a future that a lot of us thought was the right choice, he heard us, right? And he said, okay, I get it. I don't think I'm the right choice for the next 4 years. And so I'm going to pass the baton, to use all the terms that have been used, to my vice president, who has stood by my side. And I mean, this is where we all get choked up, not because this is a moment, it's a transition in American history where we are handing off not just from an iconic president to his vice president, but we are showing the world that we can responsibly transfer power before we have to, and then empower and get behind a woman who has been amazing in her own right, but is even more amazing when we believe in her. And I think for this moment, I mean, she ran for president in 2020, and it was not a secret that although I went to my first event that year, that cycle was actually for her because she declared early. I actually parked my car in a different parking lot and I was behind Pete. This is a moment that I think she's going to shine like a star. The contrast couldn't be more dramatic. Obviously, she is running as both an experienced prosecutor and a woman of the world against a guy who is a convicted felon, who is a convicted sexual assailant, who doesn't understand that moving forward includes an inclusion and a progression in humanity. She also tells the truth for the most part. He doesn't. So I am so excited for her and how she'll lead, but I'm also excited for us because watching the eyes start to twinkle in my daughter and in my mother, like both of them are excited about this. And neither of them really were like, I really wish Kamala Harris had become the presidential nominee, elbowing out Joe Biden. But I don't know a single person who is looking for the future of this country that isn't excited at her candidacy and you've just seen in the past, it's been, it's not even been 2 weeks, and hundreds of millions of dollars donated, rallies in the thousands, just starting. The idea that very soon she's going to announce her vice presidential pick, which will continue to energize folks. Then the convention. I mean, I think, and again, like my friend Pete said on a podcast this weekend, I'm really excited for the end of Trumpism, and I think she's going to deliver it. And it's not because I want to not have Republican friends. I want them back. Like, I want to have a discourse again about policy, not personality. And so I'm ready to move past that. Look, we're going to hear more about healthcare now that she's the nominee, a better healthcare system, healthcare access for all. Yes, reproductive healthcare. Yes, drug pricing. Like the stuff we needed to be talking about, we're going to start talking about again, because we're not talking about how I don't want to vote for an old man and I don't want to vote for an old man who's also a convicted felon. Like the conversation will now move on and move forward. And yeah, that's why I'm excited.
I don't even have the words how excited I am. I do think this is really important for you to give our audience some practical advice because you understand politics, you understand how votes happen, and we've got people listening all over the place. And I'm honestly scared. I listened to a podcast this weekend and they talked about how the other side has put in election deniers into
Counties.
into posts in which they will have a lot of influence in how this election goes down. And after I heard that, I thought to myself, like, we can't eke this out. It has to be an overwhelming, like, so dramatic a wave that not even the election deniers that are going to try to deny this election have any space. So what's your advice for the people listening? Maybe 2 or 3 tips to, obviously for them to vote, but how do they get other people and amplify and excite the communities that they can influence?
Okay, so a couple things. So it's absolutely true. I mean, if you listen to Mark Elias, who I think is probably was either a guest on your podcast, but he's the absolute expert in the space. He will let you know how many, I think it's like 66 lawsuits exist right now to refuse the results of the 24 election. Like, meaning that they're all working on ways to restrict access. And there are county clerks who are already saying they will not certify the results in certain counties, regardless of the outcome. So and again, we talk a lot about the election, but there's an entire conversation about the 6-week period afterwards, and then obviously the actual transition until that happens. So like, there's a lot ahead of us. It doesn't end on November 5th, but it starts on November 5th, and we've got to start it on November 5th. I mean, it starts now, but so what you're saying is true. It's also, if you want to feel like you're helping with the aftermath, donate to Mark Elias and Democracy Docket. Like, that is true. He is fighting the good fight in a way that is important, and he is an incredible success rate winning. It is also true what you're saying, which is that one of the best ways to have them to remove the wind at their sails on there being cheating, because that's what they're going to say regardless, is to post such overwhelming numbers everywhere that you can't, even if they deny or don't certify in certain areas, it won't matter, right? So we're talking about, instead of a 7 million vote difference on the popular vote, it's now a 15 or 20 million vote difference on the popular vote. It isn't just a 271 electoral college win, it's a 300 electoral college win. It's to say that if certain states that may have problematic legislatures do alternate states of electors, which again, like, who even knew these things? Like, these were fever dreams in Republican, in these far right people's minds, and now they have inserted them into the mainstream. But none of that matters if we don't post numbers when on election day. And so the first step for everyone is not just to vote, and vote where it matters. Meaning, like, if you have a choice, like, so many people have 2 homes, and I mean this candidly to physicians. If your weekend home is in a district that you can also flip a congressional district, vote there. It's totally legal. It's totally allowable. You get 1 vote. Where you exercise that vote may be up to you. And this happens all over the United States. If you have college students who are living and meet the requirements to vote in their college town, make sure they do. Make sure that everyone you know, if they're going to vote, posts an early vote if they're not going to vote on election day. Early voting in New York is my favorite thing to do because I put it into the machine, I know my vote was count, and I move on. And the Tuesday of election day, if there's a blizzard, a hurricane, a snowstorm, or I have COVID, like whatever, I don't have to wait until that day. Make sure that everyone in your family is voting. And again, you can tell them you don't care who they vote for. And the truth is you kind of don't, right? Don't play games with people's votes. Like encourage them to vote. I know people that will only encourage people to vote if they think they're going to vote like them. We are trying to advance the democracy and good conversation. So remind people that their vote matters no matter where they are. And again, if you're in a state that you think will go the way you want regardless, which was me my whole life, right? I was a New York girl growing up in the Democratic Party in Brooklyn. I didn't vote till 2016, which
Wow.
shocks people
I'm shocked.
because I didn't think my vote mattered. And for the most part, it didn't, right? And in 2016, I voted because I felt connected to the vote in a way that I hadn't before. And still, shit went sideways. But my daughter, who is going to be 17 in November, does canvassing and door knocking. And I promise you, she's voting from the day she turns 18 in every election because and this brings everything together. If you get a kid thinking about contraception and voting when they're a teenager, they'll never abandon either. Okay. And we don't need to find 35-year-olds that have let go of their right to vote and got unexpectedly pregnant more than once. So let's invest in teenagers and get them canvassing and thinking about the right to vote. And so what I would say is make it a family affair. Find a candidate you believe in and knock doors, make phone calls. If you can donate to a local candidate, that feels really good. They need much less money than the federal elections do. But it's fun. Like engaging in democracy is fun. Take it from me. And again, that's why pre-Kamala, so 2 weeks ago, I was engaged with democracy, but I wasn't having fun. And now I'm having fun again. And I like this feeling much better.
Mm. Well, this has been an absolute joy. How can our listeners, if they want to apply to an AccessBridge fellowship or ambassador program or connect with you, get in touch?
Yeah, so it's technically bridgetotreatment.org, and then you click on AccessBridge. But if you Google AccessBridge, it will be the first thing that pops up. You can apply now for either the fellowship or the ambassador program. And one of the things we say to fellows is identify 2 ambassadors to work with you if you're going to be a fellow. Go on the website now. We're taking applications now through the middle of August for the fellows, and the AccessBridge ambassadors will be more of a rolling program because it's not as formal. And then if you want to know any more, you can always find me. I'm pretty easy to find, but if you go to my website, which is darakass.com, which I only put up so people could find me, you can put in a comment and I can email you back and set up time to talk about solving these problems. But I would say AccessBridge's website, the links under leadership, it has the link to both the PDF for the fellowship and for the ambassador program. And like I said, we would love to blow it out of the water this year and have people from all 50 states and territories work on expanding reproductive health care in their departments.
I love it. And for social media, where are you most active now?
I mean, I hate to admit it out loud, but I re-engaged with Twitter 2 weeks ago because the political conversations are just more relevant. So I am still on Twitter if you want to find me at Dara Kass. I don't tweet that much, but I do have a DM section there. I'm on Threads and Instagram as well, but I would say that DM me through Twitter is probably the safest way to do it because it's the most efficient DM process for the most part.
All right. Well, Dara, it's been wonderful seeing you virtually. And will you be in Vegas for ASAP?
I will be in Vegas for ASAP. I may or may not be presenting. I will also be at Cord. I may or may not be presenting, but I'm looking forward to seeing everybody. It's going to be a crazy. And if anyone wants me to give grand rounds in their departments, please let me know. One of the ways that we're energizing residents and faculty is to come and give a full reproductive health care grand rounds on all the ways that people can work literally the next day to have care be better for patients that they see.
I love it. And we'll have all this in the show notes. Thank you again. It's great to see you.
Thank you so much. It's great seeing you too.